Hello, everybody, and welcome to the Student Success Review session on structural and cardiac disorders. A nurse is caring for a patient following their valve replacement surgery, and throughout their post-op recovery, the patient has been in a normal sinus rhythm. Suddenly, on post-op day 2, the nurse notes a cardiac rhythm change on the monitor. What is the priority action of the nurse? And it's time that you can stop the recording and try to first identify what the cardiac rhythm is and then try and answer the question. I'm going to keep going, and when we look at this rhythm, we see that this is atrial fibrillation. Now, atrial fibrillation is probably the most common dysrhythmia. A lot of individuals have it. It can occur as the heart gets older. It can occur when there's a stretch or abnormal shape of the cardiac chambers, such as what happens in in heart failure. And then it can also actually occur during stressful times, because the surge of the stress hormones can cause atrial fibrillation to occur. So let's get back to, now that we've identified what the rhythm is, what's the priority action? So the priority action is to assess the blood pressure. Why? Well, atrial fibrillation means that the atria are quivering, and so any potential cardiac rhythm that's abnormal has the potential to decrease the cardiac output. And when there's a decrease in the cardiac output, then the blood pressure can go down. So is the answer contact the thoracic surgeon a wrong answer? Well, it is wrong because it's not what you would do first, but it is an action that must be done. But you have to assess the patient when you see a different rhythm occur. You've got to make sure that there isn't a loss of consciousness, that their blood pressure and vital signs, and then you would absolutely monitor you would contact the thoracic surgeon. Now, monitor the patient is also something that you're going to do, and it is true that the rhythm's not life-threatening, but you have to ensure that the cardiac output has not gone down drastically, and doing that would be the blood pressure. And then what about administer an anticoagulant? Well, if the patient stays in atrial fibrillation, you know that anytime there is atrial fibrillation, there is a stasis of the blood in the atrial chambers, and that can lead to clots forming, but that doesn't happen in a second, doesn't happen in a day. It usually takes anywhere from 48 to 72 hours. So administering an anticoagulant is not a priority action. And again, whenever you see the words priority, we want to consider first, is there an ABC option? In other words, is there an airway, breathing, or circulation option? And so assessing the blood pressure is also part of circulation, so that is also what makes it correct. In a patient with aortic stenosis, which symptom would indicate an urgent need for valve replacement? And an urgent need of valve replacement is indicated by syncope. We've talked about valve disorders, and we know that whenever there is a valve disorder, it kind of causes an increase in the cardiac muscle workload. In other words, the ventricles have to really pump with a lot more energy and force. And also because the valve is like the door and it's not keeping blood flow forward very well, or it may not put blood forward very well, then there is a risk of the cardiac output going down. So really it's kind of the same scenario as dysrhythmias. Always, always, always with cardiac problems is there something that is altering the cardiac output. And the cardiac output is going to be indicated, an alteration in the cardiac output is going to be indicated whenever there is syncope or altered mental status. That is a sign of poor perfusion. And so whenever there is signs and symptoms of poor perfusion, then this indicates that the valve problem is a little bit more severe, and it may mean that the valve has to be fixed. A patient is in need of valve replacement surgery, so which criteria favor the use of a biologic or prosthetic valve? Select all that apply. So when we talk about the valves, we discussed in our presentation in the Learn material that there are two types, a bioprosthetic or biologic valve, and then there's the mechanical valve, and there's different criteria for each valve. And one of the criteria for a bioprosthetic valve is that if a woman is in childbearing age, then that woman, if she gets pregnant, is not going to be able to take the long-term anticoagulant that is needed for a mechanical valve. So that's one reason. And if there is a limited life expectancy, then that might be another reason for a biologic prosthetic valve. In other words, biologic prosthetic valves will last approximately 10 to 15 years. And so I've given you all of the indications here of a bioprosthetic valve. In other words, I've given you some specific examples. So I would pause the recording and make sure that you read this, because this will really help you with some of the test questions that could be on the exam when asked about what's the difference in mechanical valve versus bioprosthetic. I did give this information, but it was kind of general, and so if you're like, well, I'm still not sure, then this is some more information that I sought out from a specific article, and so I think this is very helpful. Again, pause the recording and read it. Identify the most common complications in the first 3 months after valve replacement surgery. The answer is a thromboembolic event, and this is a fancy way of saying clot forms. So whether the patient has received a biologic or bioprosthetic valve or whether they've received a mechanical valve, thromboembolic event is there, and that's because the most common complication is, this is a valve that wasn't there originally at the birth of an individual, and so therefore it's a foreign object that's been placed. There is a tendency for platelets to clump, and there can be clotting, and so regardless of the type of valve, anticoagulants must be given in the first 3 months. If it's a biologic valve, that's all that's needed. They just take anticoagulants for the first 3 months and then they're good to go. They don't need anticoagulations after that. Whereas with a mechanical valve, anticoagulation must be used for the life of the patient and or the life of the valve. What is the rationale for the lifelong requirement for antibiotic prophylaxis for any dental, endoscopic, or surgical procedure for the patient with a prosthetic valve? The patient is at risk for a endocarditis event or endocarditis. Now let's go over this in detail because, again, I'm going to tell you that students often see antibiotic and they might think of anticoagulation, especially because that's what we discussed in the previous question. And so I want you to make sure that you pay attention to words, antibiotic, anticoagulation, different thing. So if you originally thought thromboembolic event, well then you read antibiotic as anticoagulation. And we know that antibiotic prophylaxis doesn't have anything to do with thrombosis, and thromboembolic event is related to anticoagulation. So why does a dental procedure or surgical procedure? Because you could introduce bacteria. The mouth is the dirtiest place or one of the dirtiest places on the human body. And whenever they're scraping off plaque during a routine dental visit, and because there's a lot of blood vessels in the gums, you could introduce microbes. And because of this foreign valve surface, whether it's a biologic or a mechanical valve, then the patient can get endocarditis. So endocarditis is one of those things that can occur with either bad normal valves or any kind of prosthetic valve. And again, bleeding is not an issue with antibiotic prophylaxis. Bleeding is an issue with anticoagulation. But even if it's a routine dental procedure, they're not going to stop anticoagulation because it's not like it's a high bleeding risk. So bleeding is only, or anticoagulation is only going to be stopped whenever there's a very invasive procedure. So I've kind of introduced another topic here, but I guess I want to make sure that you get all of the things because we don't necessarily address these things either in the notes or in the modules that I do. So, bleeding is not an issue if the patient's going to have their mouth cleaned. It can be an issue in a major surgical procedure, and antibiotics are not going to prevent prosthetic valve damage. A patient has returned to the ICU after an aortic valve replacement. Chest tube output has been approximately 125 mils for the last 3 hours, and now the drainage has ceased altogether. Assessment reveals a decrease in blood pressure, urinary output, elevated right atrial pressure, and muffled heart tones. The patient's complaining of dyspnea, and the SpO2, the oxygen saturation, is 88%. So what do these findings indicate? Well, these findings indicate cardiac tamponade. They are the classic signs and symptoms of cardiac tamponade. Now let's talk about what the heck is cardiac tamponade and how can it occur after an aortic valve replacement. I do have the signs and symptoms of cardiac tamponade, and again, pause the recording, make sure you know these, and write them down. So let's look at the scenario and how it is that this individual can get cardiac tamponade. So whenever there is open chest surgery, and you can see when you look here at this line, that's the incision for the open chest surgery, and then they saw right through the breastbone, and that's how they replace a valve. That's how a valve job is done. And whenever that is done, you create inflammation because you're slicing and dicing through the skin, through the bone, then you're slicing and dicing through the heart, and you can get, the patient will get inflammation. This will create fluid. I say inflammation, and you should think fluid leaking. So these blood vessels will leak somewhat, and there will not only be leakage from the heart or the pericardial surface, it will leak into the pericardial sac, but it can also leak in this area that's known as the mediastinum, and that's the place where the heart sits. It's outside of the lung area, and fluid can collect in here. And whether it's in the fluid collects in the pericardial sac or whether it collects in this mediastinal space, the bottom line is it can inhibit the ability of the heart to stretch and fill during diastole. And when the heart doesn't stretch and fill during diastole, then that means that the heart is not filling with enough blood in the ventricle, and therefore it's not going to eject or shoot out enough blood. So the cardiac output goes down. And therefore, this Beck's triad is a trio of signs and symptoms where you have the inability of the heart to stretch and eject, stretch and eject. So diastole, systole is at risk. And that's why blood is just kind of hanging out there and not a whole lot of it. And that's why there is an increase in the jugular venous distension. Now, narrowing pulse pressure is something, maybe a term that you haven't heard about before, or if you have, bear with me as I introduce the information. But let's say you have a blood pressure of 120/80. The pulse pressure is the number of diastolic subtracted from systolic. So if you had 120/80 and we subtracted 80 from 120, that's 40. And any time there is a narrowing, that means that that number of 40 means it goes down or it gets less than 30, and that's a bad sign. That means there is poor heart function. So what value would give you a narrowed pulse pressure? Well, that would be a pressure of, let's say, 100/80. So if you subtract 80 from 100, now you have 20, and that's a sign of poor heart function. The other trio in the Beck's triad is muffled or distant heart sounds. So your exam person or exam writer or exam person that's torturing you, whenever you see Beck's triad or you see that there is three things, increased CVP or JVD or narrow pulse pressure and muffled heart sounds, that's the exam writer telling you your patient has cardiac tamponade. So you have to know these signs and symptoms. A patient is 1 hour post-aortic valve replacement and CABG surgery, and the following data is obtained by the nurse, the critical care nurse. There's a whole bunch of data there, and which interventions should be deployed. Now, this is probably the most challenging question that I have, and it's unlikely that you'll get it, but we're going to go through it piece by piece. If you haven't done the hemodynamic data, then I would encourage you to skip over this question and go to the next question, because this is not going to make sense. So when we talk about hemodynamic data, and that's the numbers that you see here, we're talking about the measurements that can be obtained when a pulmonary artery catheter is in. And one of the things that I taught you in the hemodynamic information is that you need to look at the values that tell you about the fluid volume or the volume status of the patient. And the volume status of the patient is that the pulmonary artery wedge pressure is slightly elevated. So the volume status, really for all intents and purposes, is pretty normal considering this patient scenario. And then we look at the cardiac output, and normal cardiac output is 2.4 or above the cardiac index. And so this patient's cardiac index is slightly out. So we see that, you know what, the heart is not pumping out as good as it should, and the systemic vascular resistance is also slightly increased. But the one thing I want to point out to you, that's really the whole purpose of this question, is the temperature is 95.6. That is markedly hypothermic. And so whenever patients are in a surgical area, the temperature in the surgical suite or the surgical operating room is usually pretty low. And so whenever the patient comes out post-op, the either recovery room nurse or the ICU nurse that's recovering critical patients needs to warm the patient up. Because what happens to you on a good day whenever it's 10 degrees below zero? Well, you know that your vessels, your blood vessels, vasoconstrict. And so the least invasive maneuvering for this patient is that we need to warm the patient up. We need to get them back into at least a decent 97 degrees temperature, because this is very dangerous whenever the patient is hypothermic. Lots of things can occur with hypothermia. And so therefore, the least invasive maneuver for this patient is to apply warm blankets. Now, there are other decent or reasonable answers, such as increase the epinephrine infusion that's going. And if you're at this point in your learning that you're like, I don't know what that means, I don't know what that indicates, then again, skip to this question. So get from this question that every patient who has a surgical procedure, whether it's a cardiac procedure or whether it's just a GI procedure or a toe procedure or whatever it is, that the operating room is very cold, patients come out and they're hypothermic and you need to warm them up. Identify the classic definition of heart failure. The classic definition of heart failure is the inability of the heart to pump sufficient blood to meet the metabolic demands of the body. Yes, whenever we see a patient who has cardiomyopathy and who has heart failure from cardiomyopathy, their heart is unable to pump enough blood forward. And because the heart is unable to pump blood forward, the ventricle will not empty completely. So that is a true statement, but it really is not the classic definition, because you really are not only is the heart unable to pump blood forward, but the heart cannot meet the demands of the body. So it's really a bigger picture than just the incomplete emptying of the ventricle during systole. Inadequate cellular perfusion, that is true. Heart failure will cause inadequate cellular perfusion, but there are other things that cause inadequate cellular perfusion. So that is not the classic definition. And there is failure of the heart because of fluid overload. It is one cause of heart failure, but it's not the only cause, and so therefore it is not an adequate definition. I would just remind you that any time there is an inability of the heart to pump sufficient blood, that the RAS activation and sympathetic nervous system activation occurs. A patient is receiving an angiotensin-converting enzyme and spironolactone for heart failure. So which electrolyte imbalance can occur? So with this question, you got to do lots of different things. You have to first think, okay, well, what does aldosterone do? In other words, what does normally aldosterone do? And in the presence of aldosterone, the kidneys will hold on to sodium. That's very, very important. Kidneys will hold on to sodium, and therefore they'll hold on to water, and that's why you have fluid overload. Well, if you're giving a drug that is counteracting aldosterone, spironolactone, then the opposite's going to occur. So with spironolactone, aldosterone is inhibited, and therefore the patient would get rid of sodium so that you wouldn't see hypernatremia, because we're doing the opposite. Therefore, hyponatremia can occur, and then the patient can have hyperkalemia because we're getting rid of sodium with aldosterone and we're holding on to potassium. So does hyperkalemia occur often? No. If the patient's kidneys are working, then they should be okay. But in the presence of kidney failure, then you do have to watch for hyperkalemia. Aldosterone or ACE inhibitor, that doesn't have anything to do with calcium. It doesn't have anything to do with phosphate. So those are incorrect answers altogether. Which drug therapy combinations will be used in the chronic treatment of heart failure? So we just talked about the things that we're going to give. We know that with heart failure that there is an abnormal or inappropriate activation of the sympathetic nervous system and the RAS, and therefore, because the patient has chronic heart failure, we would like to inhibit those so that they're not activated, and so therefore to inhibit the sympathetic nervous system, we would give carvedilol. The patient would be taking carvedilol, and to inhibit the RAS, the patient would be taking an ACE inhibitor, which is drugs that end in IL, so enalapril is a good option. Which item correlates with B-type natriuretic peptide levels? So this is a lot of information on this question. So let's go with what do we know first about B-type natriuretic peptide? Well, we know that it is secreted, it is made and secreted by the ventricles in response to stretch. The ventricles will stretch when there is fluid overload. How do you know that your patient has fluid overload? Well, again, this is a hemodynamics question, and if the pulmonary artery wedge pressure is measured and it is elevated, then the patient has fluid overload. So the answer is pulmonary artery wedge pressure. Again, this may seem a little bit confusing if you haven't done the hemodynamics presentation. Over the past 2 hours, a patient admitted with severe acute heart failure. Now, severe acute heart failure is often called decompensated or acute decompensated heart failure. So that's ADHF. So you will often see that in Dr. Reed's notes, ADHF. That just means that a patient who had stable heart failure and controlled with the drugs that we just talked about, which is beta blockers and ACE inhibitors, has had some kind of acute episode and now has acute severe decompensated heart failure. And here's the assessment parameters that are seen as they're admitted. So which of the following drug combinations are indicated for the achievement of therapeutic goals? So a kind of a complex question. It encompasses your knowledge of a lot of different things. In other words, heart failure, we know, normally encompasses the problem with fluid overload. So that is because of the RAS system, so they have fluid volume overload. And then the other thing is the inability of the heart to pump forward. So we know that the other underlying problem is contractility of the heart. So those are your two major categories of problems whenever there is any kind of heart failure, no matter what. So whenever your patient is in acute heart failure, you need to give acute medications that will address the true factors, and that is the fact that the patient has volume overload. So you would give Lasix to counteract the volume overload, and you would also give something to increase the contractility of the heart. The class of drugs that increases the contractility of the heart are or is a positive inotropic drug, and that one of the drugs in that class is dobutamine. So the answer is B. Dobutamine and Lasix are going to, or furosemide, that's the generic, and that's what you need to know. And that's the group of drugs that is going to be used. Now, you probably have noticed that I've really talked about a lot of drugs, and a lot of drugs are on exam 2. And therefore, you need to write these drugs down on your exam paper, because especially if you're the type of individual that has a hard time with drugs, make sure you write down the generic. Sometimes I do mess up, and I list the brand name because that's what this old school person remembers very well. And so you need to make sure that you have the generic drugs because all the generic drugs are going to be listed. A patient with a history of heart failure develops pulmonary edema. The patient is given morphine sulfate and furosemide. Which statement best describes the rationale for its use? So again, you're being asked, tell me about the function or the indications or the pharmacokinetics of morphine. It's something that you do need to know. So what is the answer to the question? The answer is morphine will produce peripheral venous vasodilation, and peripheral venous vasodilation will keep blood in the feet and will reduce the amount of blood that is returned to the right side of the heart, and this will reduce volume returning to the heart. So that's another way of saying reducing preload, and that will reduce the workload of the heart, because with heart failure, the heart does become overwhelmed with the demands of the body to increase its pumping ability, and we want to decrease that problem. We want to decrease the workload of the heart. A patient is admitted with an acute MI and heart failure. He's tachycardic, hypertensive. There's your hemodynamic values. And the patient is given a dobutamine infusion, but they remain significantly hypotensive. The physician has decided that an intra-aortic balloon pump is to be inserted, and it goes in through the femoral artery. So what's the primary function of the intra-aortic balloon? What is its purpose? And the intra-aortic balloon goal or purpose is to answer A, decrease afterload, and to improve coronary artery perfusion. The goal of the intra-aortic balloon pump is to decrease afterload and to improve coronary artery perfusion. If this is not something that you remember, then go back to the structural cardiac disorder and then re-listen to that portion. I hope this has been helpful. I hope you've done well on these questions. If you have any